basic t-shirt or like leggings or something, but I'm like, I'm gonna try to go all in and like, and then I'm gonna get discouraged, and it's fine. We'll get there though. Yeah. All right, let me share a screen.
I was able to move my appointment to 1:30, so.
Okay. Okay. Yeah, I forgot about it. I mean, I wasn't worried about it, you know what I mean?
Yes,
So you're fine. All right, so this is we need. It is really warm. Yeah, so if you can figure that out, if it changes, I don't think I can change it, but yeah, if we need to open that back door too, we can open that. I'm gonna just log in here and then I'm gonna go up to the lab and see if it's hot up there. Because if it's hot up there, I want to open the windows. I'm gonna need to sign into this. That's all I need, right? All right, let me run up to the lab real quick. I just need to put my food in my fridge. I want to make sure that lab is not hot. That's what I'm going to worry about. That's why I'm going to the lab, make sure it's not like anymore.
It's so nice, but I'm gonna start sweating.
Personally, I'm having lizard time over here. I don't know about y'all.
I'm worried to go to the lab and it's gonna
be like 10 billion degrees.
And it was no problem. That's what you got.
Oh, good. Yeah, because it's gonna smell like just farts.
Yeah.
It's just farts.
Oh.
Ready for the semester.
Right.
I'm at the point where I'm like kind of reaching it out, but I'm like, I can't let myself get burnt
Yeah,
out.
especially this weekend, I was like, I don't want to do it anymore.
No, literally. I was like, how much would it affect my grade if I like didn't
I was like, I'm gonna do everything, but it's going to be bare minimum to get to it.
real?
And I think we got that application tomorrow.
And then the lab one on Thursday.
Yeah.
Girl.
Wait, the lab what?
The anatomy exam.
Oh.
Lecture is.
Is it like anatomy lab? Wait, what's lab on Thursday? Oh, wait, it's like, yeah, Wednesday and Monday. Guys, that's how I am. That's just me. Yeah.
And I have, not even started for the lab study yet. I don't know.
Right.
They just opened the cadaver on Thursday. And I didn't go in this weekend because I was like, no one's gonna know anything. So the professor never told us again.
And
Then it's gonna be me and her teaching again. And I don't fucking do that.
is review tomorrow.
That's what I'm saying. How are you gonna do this review right for the test? And then
They don't.
And then all he's gonna do is read and talk. He's not gonna tell us like, oh, I chose these ink pads, like this is what.
It was
so
that she did one books.
She told me it did not.
I was like, great.
So what I did was I started, I rewatched lectures and then redid the work, smart book just to practice to smart tabs. Yeah. I got to finish today, going over those videos. For this practice videos.
Like, if you do, but
And I know she didn't fail, but
well, not necessarily felt, let's film her.
what she wanted. She
I don't know what she got,
Okay.
like, she usually
She
had
told me it was-
95.
Yeah,
She usually gets good grades, it's like, I'm so bad. Great.
yeah, that's what she told me, and I
Or
was
so
like,
bad, could be like
bad.
80, but
She did still have A in class, so I was like, okay, so,
not too bad.
yeah.
Yeah.
Yeah, she would have still. She would have.
Okay, okay.
That's why it's 76. That's why I'm going to be very soon.
Well, I don't.
Taylor will be here today.
Where's she at?
She's feeling kind of sick, so I think she should come over, but.
I mean, some problem.
Yeah, I mean, especially if you were out this weekend, I can see that, but, yes, yeah, so she's already here, to meet her today.
She's not going to allow to do.
She's, I just sent her pictures. I'm supposed to have a doctor.
Yeah, it's gonna be 75 today.
I think, well, I think it's scheduled.
We're rushing in.
Weeks out, I think probably would school just started.
Too, we're thinking about it.
I would way rather. Okay, wait. So the lab.
No, I didn't check, 'cause I think so. I submitted mine on like Tuesday though.
Oh.
I have mine done like early this week. No, I didn't send it to her. So I think she might have, well, she also submitted it late and she probably didn't.
So, I wanted to check with the last.
No, I always have like the outline report done. Like I outlined it earlier in the week and then on like Sunday,
it was like no
she
change.
watched the show and like.
Yeah. We got no change.
I feel like that, like, I don't know, I like to get it all done in one sitting. but
Yeah.
it's not the same, but I would have to do advice.
Cause I'm like,
But also like, like,
to be honest, they were kind of.
too bad.
I always kind of like,
I
and you know why?
it was so much of a deal. I was kind of pissed at you. I was like, we've already written the same.
I know, I didn't write a lot of stuff though.
Oh, when I was, my note for chapter 18 is one
Yeah.
page.
This is 18.
Well, I'm not
How,
doing
like, this
it. I
whole
put
is
my.
Yeah, like my.
right? Like I didn't write like.
Alright.
Luckily the window got left open in the lab.
Wait, that's ridiculous.
The lab is not hot, but this is.
Okay, I need to figure out when to get that, but I really get it. I didn't have a job. I had to get one.
Isogram, autogram.
No, 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 just a shadowing. I
Oh,
think I watched.
I
mean, I'm not big.
Like, oh, yeah, I listened, but like, I never learned it before, so it's like.
Okay. I just kind of looked the word breakdown. I feel like that's kind of what's helping get me through this process now. Just break the words down.
It's hard to go.
All right, double check that we're signed in, folks, and we are going to get started in a second. In here. And I can't see. Nobody online. That's fine. Just saying, if there's only 14, there's only 14.
That's why I was going to about.
She can always watch, as long as she watches that. Yeah.
Oh, I left my lipstick. Antigen talk. All right. We're gonna go ahead and get going. We're gonna do like we did last time, kind of a lecture. This shouldn't be as long, right? Now that we've covered immunology, and if you're like, man, that one talk wasn't enough for me, I posted the video for the review where I talked through the immune response again. And if that's not enough, then you let me know. You email me, but try to get some reference before you email me. So like you try to watch other videos, whether it's Amoeba Sisters, whether it's my recording, listen to the audio shorts, look through the textbook, try to get some reference. Remember that we only have this, it's just this lecture, and then next Monday is the Unit 3 exam. Okay, so Unit 3 exam is on Monday, so that's how long you have to figure out the immunology stuff. So just FYI. And then the week after that, we start our presentations. Yeah, so 2 weeks until the presentations start, 1 week until the Unit 3 exam. Another thing, come on, brain, we're here. It's time to do the work. Yes, so the presentations themselves, like your slides or your slides in your recording. If you're doing a recording, the recording has to be submitted when your slides are submitted. So not like when your presentation day is, has to be submitted when your slides are submitted. If you're presenting in person, then just your slides will be due, okay? So that's up to you. So I'm assuming if you submit just your slides, you will be presenting in person. So pretty much that's how that's gonna go. So even if you're like, hey, no, I wanted to do a recording. Nope, if you only submitted your slides, you must present in person. Make sense? Okay. Remember that you have to get those slides to me if you want me to review them ahead of time. It is so hot. I'm sorry. I have no control over it. We've already tried. Okay. But if you want me to review your slides beforehand, that you have to get them to me 48 hours before the due date, which is the 16th. So the 14th is when you have to get them to me. So you have 11 days to get me your slides. That's it. Some of you guys have already submitted them. If you submitted them over the weekend and I haven't reviewed them yet, I will review them either today or tomorrow. I don't make any promises about today because again, I didn't grade anything or look at anything over the whole weekend. So I've got to play a little bit catch up this afternoon. So keep that in mind, but I will get to you with that information in the next 48 hours. Yes. Submit them to the assignment. Yes, because even if I'm like, hey, you need to change it, you'll just resubmit it to the assignment. Yeah, there's no limit to how many times you can submit it there. Yeah, it's easier for me to track it that way. Like when you guys email me, I lose emails in other emails. And so it's really hard for me to sometimes keep up with that. So submit them to the assignment is the best way. If you already emailed it, nobody did. I don't know why I'm saying if you already emailed, nobody did. So we're good. But yes. Okay, any other questions about that? We're going to get going with chapter 17. Right, here's our learning objectives. We kind of figured this out already. Remember that the goal is to be able to actually achieve the learning objectives without having to refer to your notes when you guys are studying. Right, so the idea of chapter 17, we're talking about like diseases of the immune response or like disorders of the immune response. When the immune response goes wrong, we call this immunopathology. So immunopathology is like the medicine, the side of immunology where we have things going wrong. The immune system isn't doing what it is supposed to be doing. Now remember, our immune system is supposed to be identifying things are foreign and then marking them and getting rid of them because they're foreign, because there's a risk associated with the foreign things. But sometimes it does that in response to self or in response to things that don't cause us any harm. And so that's what chapter 17 is going to be talking about. All righty, so we either have hyposensitivities where you are underreacting to things, or hypersensitivities where you're overreacting to things, basically what we're going to go over. We're going to go over each type, but this is a good little like reference to come back to that summarizes like major examples of each of these with the different types of hyposensitivities and hyper. We're going to start off with the hyper ones first. So what is a hypersensitivity? We are having a reaction to something that is not a threat, basically, is what we're saying. So that can be self or non-self, but it's not a threat. And we're usually overreacting, and it's causing damage to our own body as a result of this overreaction. So this can be reacting to things that, again, are outside of the body or from inside of the body. So exogenous or endogenous threats. Usually endogenous, we're talking about anti-self. So these are going to be autoimmunities. The 4 types of hypersensitivities are type 1, 2, 3, and 4. At least that part's easy, okay? But we'll talk about what each one is and how they are controlled. But here's our mini breakdown here. Type 1 hypersensitivities. These are our allergies, typical allergies. This can be atopic, which is local, or anaphylactic, which is systemic. And they're all mediated by IgE. And we're going to talk about how IgE mediates that as well. Type 2 hypersensitivities. They're mediated by IgG and IgM. So not IgE here, okay? So specifically IgG and IgM, and that leads to cell damage because of activation of complement. Remember, you activate complement through the classical complement pathway. So here we're activating complement with antibody through that classical complement pathway, and that leads to the complement system basically poking holes in red blood cells. So here we have targeted red blood cells with IgM and IgG, and then it's causing that MAC, the membrane attack complex of complement, to build and poke holes in the red blood cells that they're targeting. Why would we be targeting red blood cells? Because of the different markers. The main markers that we're going to talk about are our ABO groups and our RH group for that one. Okay. Type 3 immune complexes. So this is basically like when an antibody binds with an antigen, that's what we call an immune complex. And then small ones get basically cycled out of the body pretty quickly. Really large ones get eaten up by our phagocytes, but the kind of medium-sized ones, they can get trapped in basement membranes. So what that means is like in your capillaries and in your vasculature, they get stuck in tight places or stuck in like joints and places like that, any tight spot, they can get trapped. And then our neutrophils and things like that keep trying to react to it in those tight spaces. And then that leads to inflammation in the tight spaces. Obvious one here is whenever we see that in lupus. So you get that butterfly rash. Also another obvious one, rheumatoid arthritis, when it gets stuck in the joints and we get inflammation in our joints from rheumatoid arthritis and the swelling of the joints there. So those are obvious ones with that one. We'll talk about another example that's associated with strep infection for that one too. And then the last one is our delayed type hypersensitivity. These are our cell-mediated delayed type hypersensitivities that are related to T cells. So here's our cytotoxic T cell reactions. When our cytotoxic T cell reactions react to things that they're not supposed to, okay? And those are delayed because our T cell memory can't just crank out antibody like our B cell memory can instantaneously. Your T cell memory cells, you'll have a few T cell memory cells, but they have to multiply back out in order to have their cytotoxic action. So it's delayed by 24 to 48 hours. An obvious example of that one, there's a few that we'll talk about that I feel like are very commonplace and commonly seen. And the best one that I have for you guys going into the nursing program would be the PPD tuberculin skin test. So whenever they inject a little bit under your skin, they come look at it to see if it welted up within 48 hours, 48 to 72 hours. And that's waiting for a T cell response to that. So that's a cell mediated, that's a delayed type cell mediated immunity. We'll talk about all of that as we get into it. All right. Start with type 1, as these are our allergies. An allergy is an exaggerated immune response to something that we see as foreign, but it's not really a threat. And then it has that histamine reaction. We're releasing histamine and bradykinin and all these things in response to our allergen. So an allergen is an antigen that we see as foreign, but that isn't really a threat that causes this type of a reaction. We consider them to be immediate onset after the initial sensitization. So what does that mean? That means that you had to go through your primary response and activate your B cell. Remember that whole proliferation and differentiation that we needed with the help of the captain and all of that? You have to do all of that first, and that is a delay. We have like a week delay in between. That's not immediate the first time that you see it. This is why you can get stung by a bee and be fine the first time. But the second time you see that bee, immediate response. Okay, so all allergens are this way. You had an initial sensitization, you made the IgE. The second time we immediately start reacting to it. Okay, so they're all going to be related to that. So there's a sensitization step and then immediate reaction every time after that. This can be atopic or anaphylactic. Atopic is local, anaphylactic is systemic. So even whenever you have like hay fever or allergies to pet dander or something like that, we're talking about that affecting like your respiratory system, maybe just your upper respiratory, or maybe just your respiratory and your eyes or something like that, right? But anaphylactic means we're having the reaction throughout our bloodstream and it's spread throughout our whole body. That's a huge problem, right? So that's the difference between the two. Even eczema, which is atopic dermatitis, it says it in its name, it's atopic, it's not systemic. You might have it all over your body, but it's confined to the skin reactions, for example. Make sense? I hope so. All right, the idea of allergies. This is relating back to the hygiene hypothesis. This suggests that our body has to be trained on how to respond to certain antigens, and that we have in first world countries become so reliant on hygiene and elimination of antigens that our body in some cases isn't being trained properly at early ages as to what is an appropriate antigen versus not really a threat. And so this threat versus non-threat thing is the thing that is missing out by children not growing up exposed to different antigens. If you are growing up on a farm or have spent a lot of time outdoors, you're less likely to have allergies or allergic type reactions, type 1 sensitivities and stuff like that. Whereas if you grow up on in a third world country where you have even more antigens and you have parasites and stuff like that, you're even less likely. But if you're growing up in a very hygienic, kind of metro-based environment, growing up mostly indoors and spending most of your time indoors, you're way more likely to have these hypersensitivities. And this is because our bodies aren't trained to react to antigens appropriately at the young ages where we get most of that training done. Again, your immune system is most likely to be properly trained at a very young age. So it depends on what's happening at your very young ages that determines whether you're going to have allergies later on in life. Okay. Delivery by cesarean section keeps the baby from being exposed to vaginal and stool bacteria. That can also reduce your body's ability to train the body to microbes that are in the environment as well. So stuff like that. So that's an example of how hygiene can affect your microbiome as well as your body's training with what is threat versus non-threat versus self versus non-self and stuff like that. So that's the hygiene hypothesis. Okay. All right, so here's a quiz question. The hygiene hypothesis proposes what? I clicked it, I promise. Okay, there it is. So specifically the hygiene hypothesis. Some of these statements might be true, but are they referring to the hygiene hypothesis? And not to sneeze on people. All right, so that lack of exposure to microbes can lead to development of allergies. Perfect, perfect. Okay, so we can have inhalants, ingestants, injectants, or contactants. They are what they sound like. So if you inhale it and you become allergic, inhale it. If you ingested it by eating it, it's an ingestant. So this is about exposure to the allergen. Now we know you can have food allergens that you ingest, right? And that might lead to a systemic response. So this isn't talking about how you respond. This is talking about how you are exposed to the antigen. Makes sense? So the allergen or antigen here. You are more likely to have anaphylactic responses to injectants, but can you have anaphylactic responses to other things? Of course. So, but those are the ones that you're more likely to have anaphylactic responses to. So here's how this works. We have our allergen come into the body here at step number 1. My pen out. Always forget that this doesn't click on this. So over here at number 1, we have our sensitizing dose. First time seeing this baddie, okay? So the allergen gets into the body. We have our T helper cell getting activated here. The T helper gets activated. It activates the B cell to turn into plasma cells, and it makes antibody. That's the first time you see it. Nothing much happens the first time. But mast cells in the area, mast cells, this is what this is over here, these granulocytes, okay? The mast cells collect the IgE that was made in the first response. And they wear it like little flags. And it just decorates itself on the surface. The next time that the IgE plus the mast cell sees the allergen, any other time after that, that'll cause that mast cell to degranulate. Because remember, mast cells are one of our granulocytes. What is a granule? It's those signaling molecules, those cytokines that lead to whatever that cell does in response. So if we were talking about granules and neutrophils, the signals that they send to call in other things, as well as the things they're using to digest the baddies, all that stuff. In the case of a mast cell, their granules contain things like histamine and bradykinin and inflammatory cytokines, okay? So they're gonna release that stuff. So again, we saw our antigen. The antigen plus the IgE leads to degranulation of that mast cell. And this here, whatever this is that it's releasing, that degranulation, again, that's histamine, that's bradykinin, that's other things like serotonin and stuff like this that are inflammatory and lead to that allergic response that we have. So I'm talking about histamine a lot because most of us are familiar with histamine, and that is what is causing your allergic reaction. But there's other signaling molecules too. I won't test you on what they are, but there's other ones too that are involved in that reaction. Okay. Let me erase this first before we go on. It's so hot, dude. Right? I know, and I can't blame you either. All right, so again, those IgE primed mast cells, they can stay for decades and decades in that area once they prime themselves with that. And the more they get activated, the more likely it is they're going to get activated again and again and again. And releasing those chemical mediators like histamine that have a reaction on the vasculature, et cetera. So which antibody is it that is associated with allergy in the mast cells in our type 1? Which antibody is it? Type 1 reactions here. I'm getting like some cool air, but this window does not open all the way. All righty, IgE for this one, IgE. All righty, so hay fever and asthma, prime examples here, where we have mast cells that are primed with IgE. They'll see whatever allergen in your sinus cavities or in your lungs, depending on which one we're talking about here, okay? And then have that release of histamine in those areas of the body. Hay fever is also known as allergic rhinitis. What does rhinitis refer to? Inflammation in the nose. So we're gonna get into a lot of talk, basically from here until the end of the semester with a lot of itis. Want you guys to always keep in mind moving forward, no matter what, whether you're in my class or you're in medicine, whether it's animals or people. Itis always means inflammation, period. So if there's inflammation in the area, it's itis. If you have an infection or disease in the area without the inflammation, we call it osis. So we're going to talk eventually in chapter 24, but it's coming in unit 4, right? About vaginitis versus vaginosis. And so that's an example of a difference where we have to keep in mind that if the vagina is inflamed, vaginitis. But if there's an infection in the vagina, but no obvious inflammation in the vagina, and that is osis. So BV, for example, is bacterial vaginosis. There's no inflammation in the vagina. BV, however, can lead to inflammation in the pelvis. So maybe not in the vagina, but in the pelvis. We're talking in the upper part, so in the actual uterus, in the fallopian tubes, in those areas. Okay? Yes.
Different, like bacteria or whatever.
Yes, it is. So we'll talk about that too when we get into that in chapter 24. So we get into 24, when we get into 19 through 24, and start talking about those different diseases. Keep in mind that some diseases lead to itis and some diseases don't. And you'll need to know the causes of all of those diseases, like the bacteria or the viruses, or maybe it's both, or maybe it's, whatever. So we'll talk about all that when we get into 19, but this is getting into that idea of itis. And so we have it in the name of this disease, and we often do, okay? Like meningitis, what's inflamed? We have itis, inflammation. What's inflamed? The meninges, the covering of the nervous system, okay? So here, what's inflamed? The nose. Rhino is the nose, but rhinoplasty and stuff like that. So rhinitis, allergic rhinitis. We can also have rhinitis that's non-allergic. So if you have a cold, you can have inflammation of the nose, but it's not caused from an allergy, right? So just FYI, keep that in mind. All right, so allergic rhinitis here is hay fever, any type of hay fever. So this could be allergic to pollen, anything seasonal, sort of like that. When we talk about like pet dander allergies, that can lead to allergic rhinitis as well, and that sort of thing. Asthma, here we have impaired breathing from bronchoconstriction in the actual lower respiratory tract, so in the lungs themselves is where we'll be having that inflammation. You can have asthma caused by inhalants, but we actually find that asthma is typically usually caused by other things, not inhalants. So you can actually have asthma as a result of what you can eat or injectants or other things like that. So it's not always inhalants. And this is true of eczema as well. Almost like every single case of eczema is rarely caused by a topical something, contactant. They're almost always caused by something else, an inhalant or an ingestant. It could also be due to chronic stress and things like that. Because remember, stress triggers your inflammatory response too. All right, so eczema is also known as atopic dermatitis. Right? And here we have skin lesions that are going to be inflammatory. They can become scaly or crusty in severe cases like we have up here. But anytime like I am prone to stress-induced eczema that I'll get on my eyelids or like on the sides of my face or the top of my face. I always get it on my face. It can't just be like on my back or something. Wouldn't that be nice? but it's on my face always. It's not from any specific thing. It doesn't matter what product I use, even when I use like very, very gentle things or whatever, that's not a contactant issue. It's basically your mind's triggered from stress. But in this case, we're talking about being triggered from an allergy. So an allergic response to certain things, okay? Food allergies can be atopic response or even anaphylactic. We can have eczema from food allergies, hives, rhinitis, asthma, and sometimes anaphylactic. We can even see GI symptoms associated with certain allergies. So you might have abdominal pain, diarrhea, and things like that from certain, or even development of IBS or IBD as a result of these allergic reactions to things. This can be from peanuts, fish, milk, wheat, eggs, shellfish, and soybeans. You might have very severe reactions or you might have mild ones. It just depends on you and your body and how you react to them. All right, drug allergies, usually either ingested or injected, but you can have reactions to a lot of different types of drugs. Most commonly, we see this with the penicillins, right? Penicillin-related drugs, as well as our sulfa drugs. Those are the most common ones. You can have allergies to aspirin, opiates, and then the contrast dyes that we use in x-rays, like the iodine-based dyes, for example. Systemic anaphylaxis, usually, like I said, typically associated with injectants, but not always. You can have this in relation to drugs, but you can also have it in relation to bee stings and certain types of food, for example. But very commonly do we see this with bee stings. If you've seen My Girl, then you know about this. But it's also one of those things that like you have to have that initial sensitization. You may have been stung once in your life by a bee and been like, I didn't have anaphylaxis, I'm not allergic to bees. But it's not the first time that you have the reaction. It's the second time and every time after that that you would have the reaction. It only takes one to kill you. So that's the difference with that sort of stuff. That anaphylactic response can be deadly within minutes. Yes.
Is it true that like you're not supposed to give someone, I heard this from someone with an allergy, that you're not supposed to take someone's like EpiPen and do it for them?
Why?
I don't know. That's what she said.
If you, so here's the thing, right? If somebody is having an anaphylactic response and they can't get the cap off and do it for themselves, then you need to do it for them. But if they can do it for themselves, let them do it if they can. So usually most people that are prone to that and already have an EpiPen, they're usually going to feel those symptoms coming on early enough that they should be able to administer it themselves. Or like if you're allergic to shellfish and you smell shellfish or you see it or something, you haven't had the reaction yet, you might give yourself the Epi shot. But if you're already at that point where you can't breathe or you're starting to go and you can't get the EpiPen, absolutely give somebody the Epi shot. Okay. So this is like where we'll start talking about treatment for this type of a thing as well. There are drugs that can block allergy. We have things that block the IgE production, things that block the degranulation, things that block the action of the chemicals later on, and all sorts of stuff. We often call these anti-inflammatory drugs. They either inhibit the production of IgE or something like that. These often also are steroids. Steroids have a lot of this action, so they will inhibit that inflammatory response. Absolutely no steroid ever should be taken long-term. And no anti-inflammatory should be taken long-term. It inhibits your immune response. Inflammation exists for a reason, right? We learned about that. Your innate immune response leads to inflammation. We have inflammation for a reason. So if we inhibit inflammation, it's usually inhibited systemically. We can't inhibit it just for that one little reaction. What you're allergic to, I don't know, pet dander or something. We're constantly inhibiting your inflammatory reaction. We inhibit it systemically for all inflammation. So that's a huge issue. So if you have an inflammatory disorder, like let's say lupus or something autoimmune like that, and you're on Humira or something like that to help dampen your inflammatory response, long-term, that leads to significant increase in susceptibility to infection, significant. So it leads to what we consider a hyposensitivity or, basically a reduced immune response. What I'm trying to say. Okay, that's fine. So we often reach for antihistamines, which just block the histamine response, which is more associated with just allergies, okay, or that IgE mast cell degranulation response. Those are a little bit safer. Antihistamines are much safer than anti-inflammatory like steroids, which are more broad. Okay, so antihistamines can be reached for. They can be over the counter. They may be able to cross the blood-brain barrier or not, which we'll learn more about the blood-brain barrier. We talked a little bit about it, but The blood-brain barrier basically can block the certain action of some drugs or let certain actions cross. And so, for example, Benadryl can cross the blood-brain barrier. That's why it makes you feel tired. But Zyrtec can't. But it's also an anti-inflammatory. So that's like, or it's also an antihistamine. So that's why we will actually like tell people, hey, Zyrtec has a similar action to Benadryl, but it doesn't cross the blood-brain barrier. You shouldn't feel as drowsy. Okay, so there's that. So but which one, you need more of a buildup effect of the Zyrtec. So it's a little bit slower acting, whereas Benadryl is more quick acting. But even then, if you're having an anaphylactic response, Benadryl ain't gonna help you because you're having that reaction now, and you do not have 30 minutes to an hour for the Benadryl to kick in. You don't. You have minutes typically. And I mean minutes, less than 30. I'm talking like 10 minutes or less, typically in anaphylaxis. So antihistamines and steroids that are taken orally, that sort of stuff, are not going to be effective at controlling that sort of thing. All right, epinephrine. Epinephrine is usually what we would use to treat anaphylactic reactions. There's basically like epinephrine that's delivered medically, and then the adrenaline that's produced by your body. They're the same. It's just how they're being delivered. So adrenaline is what is made by your body, but epinephrine is the medical version of that we administer in EpiPens and things like that. So what does epinephrine do? It basically reverses the constriction of your airways so you can get more oxygenation back to your brain and your tissues and things like that. Because the anaphylactic reaction can actually close off enough blood flow to your brain to kill you. You will die. So we can't have that. So this will open that up. So when we talk about epinephrine, if you need to use an EpiPen or if you know somebody that needed to use an EpiPen, the effect of an EpiPen only lasts 15 to 20 minutes. Yes.
So from like epinephrine that's used in a code blue scenario in a hospital to an EpiPen in like an EpiPen, what is the difference between the epinephrine?
Typically just the dosage.
Okay.
Just the dosage, yes. So in a hospital-based scenario, we can do calculations based on that person's height, weight, and everything like that. Whereas an EpiPen that's in like the pens that we have, right? You're supposed to click the top, take the top off and push down the plunger once it's in the leg, right? It's in one smooth motion. And it should go directly into the large muscles. If you're ever dealing with somebody that's having an allergic reaction, you know they have an EpiPen into a large muscle group, usually the leg, because there's less fat there typically to block the needle from getting the injection into the muscle tissue. You don't want to inject it straight into a bloodstream or something like that. You want it in the muscle. It's made to work that way. So into the muscle. You don't want it in a fatty part of the body either because that's going to slow the dissemination of it. So you want it in the muscle. That's why we usually go for the leg because it's an easy, big muscle group right there in the quads. So that's where you want to go for it. And that dosage is usually small enough that we wouldn't have to worry about causing that person to go into cardiac arrest from the amount of that. There's not as much risk there. Did you have something to say, John?
Can I share something?
Yes, absolutely.
It's the concentration. So like Epi 1:1 is 1 milligram in 1 milliliter. So the cardiac Epi that you've seen before is 1 milligram, but it's in 10 milliliters. So the concentration is different since you're giving it intermuscular, but the dosage is the same. So an EpiPen is 0.3 milligrams. So it needs to be a smaller amount since it's going to muscle. EpiPen Junior is 0.15. So they're already a set dose.
Gotcha.
So, for example, if someone's in anaphylactic shock, which is a distributed type shock, so that means there's a container issue, you can't give Epi-IM if they're hypotensive because they are not perfusing.
Yeah,
your
I don't have
tissues
like
enough.
enough.
So you'll give it IV, you'll use the Epi 1 to 10, which is 1 milligram to 10 milliliters, but you'll only give 0.3 milligrams, which would be 3 milliliters of it. It's the same dose, it's just given differently because of hypertension.
Yes, and my understanding, my understanding too, John, is that it's going to be based on your body weight then. If we're giving it intravenously, we want it to give it basically based on the size of the person, whereas the pens are like dosage based on if you're adult or child. Yeah.
Kids are weight based, and then depending on what physicians ordering it, they'll either do 0.3 or 0.5 milligrams.
Yeah.
They slowly started to increase the dose.
That makes sense, yeah.
Because sometimes anaphylaxis doesn't even really present in traditional.
So for people that might be watching this online, since it's recording, we'll post this later. What he's explaining is basically like the difference between the EpiPen versus the dosage that they'll give you through IV or something like that in a hospital is that the EpiPen is going IM intramuscularly. And so we're relying on, perfusion basically from the musculature into the vasculature from that. But if they don't have enough blood pressure to carry that medication from the musculature, you're already at a place where you're hypotensive. You're already at a place where your heart isn't getting enough blood to your extremities. Then we'll want to give it via IV, and that IV dosage is smaller because it's going directly into the bloodstream and into the heart, but it will help open up the blood flow to the other areas of the body as well. So that's basically the difference between the hospital versus the EpiPen dosages. Did you guys, anybody else have any other questions about that or any other
No,
stuff
he
you want to add?
explained it like perfect.
That's really, that was perfect, yes.
I don't think I'm ever gonna forget that.
Which you guys will talk more about that, obviously, if you go into whatever healthcare that you guys are going into. And this stuff is relative to, like, we talk about this stuff a lot in relation to people, but almost all of this stuff relates back to vet too. If you're going into vet, this stuff still relates back. Okay, so I just want to be clear about that too. So another thing that's important to remember about epinephrine, its effects only last 15 to 20 minutes. So if somebody has done an EpiPen because they're having an anaphylactic reaction, that is not a cure. So what happens is if somebody has actually had to pull out their EpiPen for a legitimate reason, they should be heading to the hospital immediately or call 911 at that point too, because that epinephrine will wear off and then that reaction will continue as long as the trigger is still there. So, and almost always it will be there long enough past 20 minutes. So we want to be sure that we are getting that person the care that they need, get them to the hospital so that we can treat them appropriately, whether that means administering more epinephrine or including antihistamines or steroids or things like that. All right, here's our quiz question. Select all that apply. What is the preferred way to treat anaphylaxis? Kind of a little bit of a trick question here because these two of them should be the same thing.
Definitely lorazepam.
Yeah. You might need the lorazepam after for the recovery.
After the debrief.
Yes. So this is going to be epinephrine or adrenaline. Now, again, epinephrine is the same thing. It's just we're talking about the hospital administering it versus the body. We can actually trigger the body to make its own adrenaline response as well. So it's not going to be as effective that way, but this is just terminology here. Okay. All right, desensitization. It can actually cause you to be desensitized to whatever your allergen is. This is like training your body to respond differently to the allergen. Are we still going to have an antibody response to the allergen? Yes, but it's shifting the antibody response to IgG. So we already know if you can switch to IgG, it's our most powerful antibody response, right? So, but if we, for whatever reason, we saw pet dander and we triggered IgE, that's what made you allergic to the pet dander. For whatever reason, did the same thing with mold. Maybe I'm allergic to mold. I'm like really allergic to mold. So you'll have this going on with your IgE response and your mast cells. But if we can give you little doses of mold or pet dander or whatever, and then have certain trigger cytokines and stuff in the injections, we can trigger your body to switch to IgG instead. Then you have enough IgG to bind with the allergen very quickly, very fast, and eliminate the allergen before you ever interact with the IgE that was on the mast cells. So it's blocking that from happening before we get to the degranulation. So we don't degranulate, basically. So that's how desensitization works. It doesn't mean eliminating the immune response. It means shifting it to a different type of antibody, IgG instead. All right, so we're going to move on now. We're going to start talking about the type 2 hypersensitivities now. Okay, any questions about the type 1 before we start moving on? Type 2 hypersensitivities basically rely on alloantigens, things that look foreign to you, but are self to other people. And are they dangerous to us? No, but our body still sees them as foreign. So it reacts to these. These all rely on IgG and IgM, and that trigger the complement cascade, and then leading to the membrane attack complex, leading to lysis of blood cells as a result. There are 4 distinct blood types, A, AB, B, and O. Okay. There are other ones outside of this that are more rare, like the null type and stuff like that, but we won't be talking about that in this class, okay? So if your genes, so this leads to our Punnett square stuff that we never did in class, but I'm going to cover it just a little bit so we have some reference. So if my mom, for example, my mom is a type A. I don't know what her parents were, but my mom was an A and my dad was a B something. Okay. I am type A come on thing. I'm a type A, so one daughter is an A. I'm an A positive. And the second daughter, my sister's an AB positive. Okay. So I know for a fact that my dad, just by looking at this is mother. So my mom carried 2 genes, one from her mom and one from her dad. And my dad carried 2 genes, one from his mom and one from his dad. Okay, everybody carries like 2 genes for everything, right? So if my mom was AA and my dad was BB, again, a B from a mom and a B from a dad, and my mom an A from an A, then the only children they could have would be AB. You see how we bring across or we bring down? You see how those would match up? That's how the Punnett square works, okay? So I know for a fact they couldn't be AA and AB or AA and BB. They couldn't be because I'm an A. So how do we know? And let me tell you, there's no milkman situation here, okay? I couldn't be more like my dad if I tried. Like I look like him, I sound like him, I act like him. All right, so we know that this isn't the case. I don't know what my mom's is, but I can tell you that my dad's must be B and O. Because if he was a B and an A, he would be AB blood type. Because if you have a B, you must express the B. If you have an A, you must express the A. We tracking? If you have an O, it hides. It's what we call recessive. Okay, so if he's a B and an O, he would still have a B blood type, but he could pass on the O allele. So for example, if we brought down A and B, it would be AB. I don't know what the other one is for my mom, but she would have to be an A and an O, or a B and a whatever, or a O and a whatever. I don't know what. So this could lead to an AB and an AO. This, depending on if the X is an O, would be a B and an O, or it could be an A, it could be an AB and an A. I don't know. I can't track it, but we know she had to have at least we know she's an A something. Okay. And I'm betting she's not an AB. She could be an AB, but I don't think she is. Those are uncommon. The most common blood type in the world, especially in the United States too, but in the world, is O positive. So a lot of people think, oh, O's are rare. They must be because they're recessive. No, they're not. There is a genetic reason for this. Well, we'll say we'll say a natural selection reason for this, an evolutionary reason for this. O's are less susceptible to malaria. I don't know enough about it to tell you why. I just know they are, okay? Mosquitoes actually prefer O blood. There's a genetic reason for that too. We need to bite more of the O's in order to get them more infected. But having an O blood type means you're less susceptible to malaria. So our ancestors died off less if they had the O blood type. And so that favors carrying on the O gene. So that's why probably why we have more O's in our population. Okay. Now, this just has to deal with a sugar marker on the surface of our red blood cells. We're going to talk about this, okay? Let me delete these. Okay, here it is. Type O looks like this. It's a red blood cell with a sugar, with a base on it, a common marker. If you're an A, you have that plus an A sugar. If you're a B, you have that plus a B sugar. If you're an AB, you have that plus both of them. Are we tracking that now? We can see the picture. Everybody's seeing that. Okay. So if you have the A gene, you have the A sugar. If you have the B gene, you have the B sugar. If you have the A gene and the B gene, you have both sugars. If you have the O, you don't have the sugars. Now think of this in perspective of what your body has seen and what has trained to look normal to it. If you have had the A sugar, B is going to look foreign to you, right? If you have the B sugar, A is going to look foreign to you, right? If you have had the A and the B sugar, what would look foreign to you? Nothing. A looks normal to you. B looks normal to you. O looks normal to you too. because you have that base built in. Everybody does. O looks good to you. A looks good to you. B looks good to you. AB looks good to you. AB blood types are the universal recipient. They can get any blood type. They're not going to feel like any blood type is foreign to them. They won't attack any of the other ones. Okay, so AB is the universal recipient. Now let's talk about the O's, shall we? They're the universal donor because anybody can receive O. We all have it as our base. We tracking that? We all have O as our base. So if you're A, O looks normal to you. If you're B, O looks normal to you. If you're AB, O looks normal to you. If you're O looks normal to you. That's why O is the universal donor, but there's a problem for the O's, okay? If you're O, A looks foreign to you. If you're O, B looks foreign to you. If you're AB, you look foreign. The only blood type that O's can get is O. And it's not the only marker on the blood cell surface, right? The A, B, or O blood group is one type of marker. There's a second marker on our blood cells, the RH group. And that's what makes you plus or negative, positive or negative. So I'm A positive, so I have the RH group marker. My body sees that marker as normal. If I'm A positive, can I get a negative blood? Yes, yes, but not the reverse, right? So it's just like the O thing. If I'm RH negative, that just means that that antigen isn't there. Nobody sees that as weird. Everybody can see that as normal. If it's RH positive, positives see that as normal, but negatives see that as a new antigen. Why is that thing here? And they could attack it. So if we want to get more specific, O negative is the universal donor. And AB positive, which is what my sister is the universal recipient or acceptor. So my sister, being AB positive, can get any blood type ever. Good, nice for her, right? ABs are pretty uncommon. We don't see a lot of them in society. Okay, so even AB negative is the most uncommon blood type. AB positive is pretty close behind it. B negative is kind of behind it. So those are kind of random on how they're sorted in the population. The most common blood types are O positive and A positive, easily, hands down. So O positive and then A positive. Okay. And then depending on what blood product I want from you, if I want your red blood cells or your plasma or your platelets, that depends on this stuff too. And it's different depending on the blood product of what I might want to use for what. So that stuff gets a little more complicated. We won't talk about all of that stuff. This is the idea first, talking about what's on the surface of our red blood cells. Okay. Here's another little chart here. Again, percent incidence in the United States, 45% in the United States is O and 41% is A. So quite common to be either O or A. But again, O positive is way more common than O negative. And O negative is our universal donor, not O positive. All of the positives can get O positive, but the negatives can't. Luckily, the negative is a less common trait. But if you're a negative, you can only receive negatives. Positives can receive positives or negatives. Yes. Yes, and I cannot stress enough how important it is for hospitals to keep O negative on the shelf, right? If it's the universal donor, if somebody comes in from a car accident, it takes about 30 minutes to an hour to type and cross somebody. So that means that if you're coming in and you're bleeding out and you need blood right away, we're giving you O negative until we can figure out what your blood type is. So the first thing first, when somebody comes in from a trauma, we draw their blood for a type and cross. But we can't wait on the type and cross to give the infusion. So we'll start with O negative. That means if we have a mass casualty event, we're going to go through that O negative quick. And if somebody comes in late in the trauma incident, whatever it is, whether we're talking about a 9/11 event or anything like that, a Murrah building bombing, something like that, where hundreds of people are injured and might need blood transfusions. If you're an O negative and you come in late in that event, you might not have any blood on the shelf. Even at Baptist and places like this, it's not like that is always kept on for like hundreds and thousands of people to come in injured. It's a rough time. So that can be an issue. And we have had incidents where we'll have to like medi-flight blood from a hospital to another hospital because we don't have enough blood on the shelves for people. Keep them alive. So this is an issue. So if you are an O negative person and you are healthy enough to donate, please donate. We need to keep it on the shelves for just in case times like that, right? So when they say that stuff, like O negatives are easily the #1 blood type that we want blood on the shelves for. Now, once we figure out that you're an A positive, we're going to transfuse you with A positive, right? But that could get delayed the more people whose type and crosses are waiting in the blood bank and stuff like that. Make sense? Okay, so O negative is the universal. Okay, so this gets to that positive or negative. This is the RH factor. This is where we start talking about ROGAM. You guys heard of ROGAM? Probably have. If you've had a kid, you've almost certainly heard about it. And if you're going into nursing, you've likely heard about it before. So somebody who's RH positive versus RH negative. Again, if my mom was a positive, no, come on. She almost certainly was. She doesn't know her blood type. This is my mom. I don't know what to tell you. I love her, but that's because she's my mom, more or less, okay? But my mom was positive and my dad was positive, and they both carried positives, and their kids can only be positives, right? Whatever. So that's probably what it is. I don't know. This is the Punnett square thing again. But again, we won't go over this. But the only way you can be negative, RH negative, is if you get 2 negative alleles. Because having a positive from a mom and a negative from a dad, if this is what your genes were, then that would be positive expression because it is a dominant trait. Yes, it must take 2 negatives to make a negative. Yes. So you know then that you must be this. Yeah. Do you know what the father? I don't know if it's your husband or not. Yeah, he might not know his. So in order for that, so if you're the mom, you must be a positive and a negative. You must be. That's your genes. That would mean you're a positive, but you're carrying the negative. And so we know that the father must either be a negative or a positive. He was a positive and a negative. You could have genes, you would have a kid that could be plus, minus, or minus. This is the kid that would be the negative. Are we following that? Because the plus, if it's there, must be expressed. Yes.
So do most kids have, like, most families, like, have the same, the same parents had 5 kids, they all have the same?
It depends on the genetics, right? So you can see that here. So this is ratio based from kid to kid. So if we have, someone, Jordan, if we had plus negative hanging out in the genes, she had positive blood type, but her kid ended up having negative. Well, let's say that, the father over here is again, positive blood type, but he's carrying the negative. We have a 25% chance every time that they have a kid that it could be a negative. And that number doesn't change from having more kids. It's every time that they have a kid, it could be 25% chance of having a negative or 75% having positive. Are you guys following that? Now, if he's a negative, then that would be negative, positive, negative. I should have drawn that better, but you get the idea. It's minus, 50% chance. You guys following that? So that's how genetics really works. And that's if you guys ever take a genetics class, which is not required for going into nursing or vet tech. But if you go into higher levels of education, you might have to take a genetics course. You're going to get way more complicated than this. And some genes affect other genes too. So FYI, but that's how Punnett square, if you've ever heard of it before, okay? So we could say, depending on his blood type, it's either 50 or 25% chance each time that they have a kid, okay? So that's a good question too. Okay, so anyways, if I'm telling you that you are a negative blood type, right? And you could potentially, let's say if you're a negative blood type, you're a negative. This is the mother, okay? It's important that it's the mother and that the father, if he was a positive blood type, doesn't matter what kind. You have a chance for a positive, negative, a positive, negative, a negative, a negative. There's, in this situation, a 50% chance of carrying a baby that's got a positive blood type. Well, if you're negative, positive looks foreign to you. We could agree on that, right? It's the same reason why A can't receive B, because B would look foreign. It's the same thing here. So positive looks foreign to negatives. and you would make antibodies against it. So you might be sitting there thinking like, well, then if you're an O mom and you have an A baby, couldn't you have antibodies against your baby there as well for the ABO antigens? Absolutely. But it's less severe than the RH. The RH is a big trigger. The ABOs are smaller triggers. So I'm already telling you, if I'm an A, if you infuse me with my sister's blood, which is AB, she's my sister, but you infuse her blood into me, my antibodies will attack the B on her ABs and poke holes in her blood cells and then leak their contents, lysing her red blood cells in my bloodstream within minutes of receiving her blood. And that could lead to hemolysis of her blood cells, right? Hemolysis, breaking open of that. And then that leads to shock response and death, usually, almost always, death. So if I'm telling you that could happen from the ABO group, but I'm telling you the plus and the minus is more severe, that's a problem, right? So somebody who is negative mama carrying a positive baby, her body naturally will make antibodies against the positive in the baby. Due to the placental barrier, this doesn't affect the baby until the placental barrier is ruptured. When does the placental barrier rupture? During birth. So the whole pregnancy, she's building up the antibodies to the baby. But once we rupture the placental barrier during birth, the antibodies can attack it. So you'll carry a healthy baby all the way to term and give birth to it, and it can die within minutes. And this happens still today. RhoGAM prevents it. So again, this is a sensitization process where I can have a baby the first time. I'm a negative, I can carry a positive baby the first time. And there's no problem at all. But it's the second baby that's the problem. I had to build up the antibodies the first one. You don't start making blood cells until later in the pregnancy. So the baby doesn't. So you might not have antibodies developing in time really to harm the first baby. But that second baby, that's where RhoGAM comes into play. You will almost always lose the baby if you don't give RhoGAM in time. Okay? Almost always. So we'll give RhoGAM. RhoGAM is an antibody. It's an antibody that blocks the other antibodies so that they can't attack the baby. And that's what RhoGAM is. Okay. This is a syndrome called hemolytic uremic syndrome. Okay, first we got the question I forgot about. What types of blood can a person with B negative? If you are B negative, what types of blood can you receive? See if we're getting it. Uh-huh. Yeah, and it's pretty routinely given. So nowadays, most often what'll happen is we will blood type the mama during like the gestational phases. So early on in pregnancy, we will blood type the mom as part of the care for like treatment as prepping for pregnancy. And if you are negative, then we know we're just going to give you RhoGAM. It's not harmful to give it. It's not going to have negative side effects. So if you're negative, we'll just give it because we don't know if you have miscarried, and you might not know if you've miscarried or developed antibodies or anything like that. So we just give it typically to negative mamas. So she probably did get it. I know that my husband's mom did. She's an O negative and he's an O positive. So anyways, so yes, so if you are a B negative, you can receive B negative and O negative, and that's it. All right, we already covered this universal stuff. Okay, which one is the universal recipient? That means the one that can receive any blood type. Not the universal donor, the universal recipient. This was a quick one. All right, AB pause. Okay, so death is a common outcome with the wrong blood type, leading to shock, hemolysis of the blood cells leading to shock. And that RH compatibility is what basically controls hemolytic disease of the newborn. That's what it's called, hemolytic disease of the newborn. Again, negative mamas attack positive babies, not the other way around. If I'm a positive mama and I'm carrying a negative baby, the baby's fine. There's no risk. Negative mamas with positive babies is the risk. Okay. if I am an O mama and I have an A baby, there is some risk, but it's almost never going to lead to death. More commonly, if you're an O mama and you have a baby, and it's not no RH incompatibility, like O pause and an A pause baby, okay? The O mama can make antibodies to the A, and it could lead to what we call the yellow baby. So having bilirubin. That is from the red blood cells being broken up and things like that, leading to problems with the red blood cells, leading to hemolysis, and then that leads to the liver releasing the bilirubin and building up in the skin, and then you have to put the baby under the UV light for a little bit. That's often caused by the ABO reactions, but it's a RH that's life and death. Okay, we good? Here's a question about it. When a previously sensitized RH negative mother has a second RH positive baby, what does that cause? Hopefully I said it enough that you know what it is. Be specific with your answers. All right, so red isn't wrong, right? It is a blood group incompatibility, but specifically in this scenario, we're talking about hemolytic disease of the newborn. So good job, guys. You're good with that. All right, moving on to the type 3 hypersensitivities. This is our immune complexes. Again, we have buildup of antibody and antigen, and it gets caught in the basement membranes of our vasculature or in our tissue. So we get buildup of these guys in tight spots. This is often in capillaries. This can cause damage to the heart and the lungs, the blood vessels, the joints, the skin where the capillaries are often pretty fine underneath the skin, and even the kidney where we have a lot of gas exchange in those fine vasculatures in the kidney, okay? So this is buildup of these guys, and then we have neutrophils coming in and trying to get rid of them and attack and causing inflammation in those areas. It's what causes the butterfly rash in lupus. It's what causes the inflammation in the joints in rheumatoid arthritis. The example that we have here of this classic type 3 type of reaction, it's called, and it's a mouthful, okay, acute post-streptococcal glomerulonephritis, okay? So the glomerulus in the kidney is where we have a lot of that toxin exchange in the bloodstream, getting rid of toxins from the blood and then filtering out that stuff in the kidney. This happens in the glomerulus. And nephritis, again, nephro means kidney. So it's the glomerulus of the kidney. Itis is inflammation, okay? So that's the breakdown of these words. It's post-streptococcal because it's after you have a strep infection. So not everybody gets it, so just FYI. But some people who get a strep infection, they build up these immune complexes that get stuck in the kidneys. And then because of that, them getting stuck in the kidneys, it leads to inflammation in the kidneys. And that's what this glomerulonephritis is inflammation in the glomerulus of the kidneys, okay? It's acute. It should clear up on its own, but it can cause kidney damage, and it can be severe kidney damage too. Just depends. Depends on the patient. All right, what type of hypersensitivity is associated with acute post-streptococcal glomerulonephritis? Did you guys remember? So questions like this are common on the exam for this type of stuff. What type of hypersensitivity is it? So we know two things about it. We know it is immune complexes, but immune complexes are type 3. Blood type, IgM, and IgG, blood type rejection is type 2. Allergies is type 1. Okay. We're going to talk about type 4 next. These are the ones that are involving the T cells. Again, we have a T memory cell, cytotoxic T memory, that gets activated. We have to multiply them out first, and a couple days later, you'll see the inflammation of it. Okay. What types of hypersensitivities are these? They're delayed. And the PPD Manito skin test for tuberculosis is a common example of this, of one that is in vivo. Anybody heard those terms? In vivo, in vitro, in situ, in utero. Some of them are obvious. Vivo means alive. Vivo, like viva, okay? So just think of like alive when you hear vivo. If it's happening in the body, that's in vivo. Vitro means imaginary, but really like in practice, what it means is like in a test tube. So whenever I swab your nose and I put it in the test tube and then test it, that's in vitro. Am I testing it in your body? No. So that's not in vivo, that's in vitro. Makes sense? So most of the tests that we're used to seeing are in vitro. If we're doing a test on like we get a biopsy of somebody's breast tissue and then do a test on that breast tissue. We call it in situ. It's in the situation is how I remember it. We haven't completely dissociated from the tissue itself. Kind of an in-between, in situ. And in utero, obviously in the uterus. Okay, so those are some terms you might want to be familiar with moving on into future stuff. All right, contact dermatitis. This is not atopic dermatitis, but contact dermatitis. You contacted something and then had this type 4 reaction to it about 2 days later, 2 to 3 days later. Poison ivy is the most common example of this. If you go out into the woods and you get poison ivy, do you start developing the poison ivy rash within minutes? No. So remember, allergy responses are instantaneous to within like minutes maximum. Whereas this stuff is like a day or 2 later. So usually poison ivy, it's like a day or 2 after you contact the thing, you'll have the rash. Jewelry and cosmetics, some stuff like that. You can be allergy type 1, or you can be contact dermatitis. Me, these earrings that I have on right now, I can guarantee you that in the next couple of days, I'll have a rash from these earrings. But is it bothering me right now? No. I'm allergic to a lot of different, I can pretty much only wear silver and gold and stainless steel. Cheapy earrings, which are the ones I can afford, I know I'll have an allergic reaction within a couple of days. So I can't wear cheapy ones all the time, but they are cute, okay, and affordable. So I take the risk, right? And so that sort of stuff. So if it happens within a couple of days of exposure, it's usually contact dermatitis. And it's usually mediated by your T cells. Your T cells are killing self cells because they think self cells that are stuck with all this, whatever it's stuck with, the metal or the goo from the poison ivy or whatever, they think it's self cells are infected inside with things. And so they're attacking them that way. Okay, so that's what's happening with that stuff. Again, we have a chemical on the surface. We have, macrophages or dendritic cells presenting it to our T helpers. We activate our Th1 response, and then they lead to macrophages and cytotoxic cells killing the cells in that area that's contacting the goo or the metal or whatever it is. And we have blistering and destruction of the actual tissue as a result of that. So this is what leads to contact dermatitis there. And there's a difference, right? If you have an allergy that's like the typical allergy where you get hives that itch and stuff like that, it doesn't present with this crusty, nasty stuff either. So it's a different kind of reaction. If you're getting this crusty, nasty a couple days later, it's probably contact dermatitis. Think back to something you were exposed to 2 days prior, not within seconds. Okay, so that's the difference there. All right, this is also what drives graft rejection. So the reason that I would reject your kidney is because of MHC1. My MHC1 looks different than yours, and yours might just be chilling. But to my body, it looks like MHC1 calling out with something foreign on its surface. And so my T cells will start killing it. So this is what leads to graft rejection. If we haven't seen that MHC1 before, then it won't be for a couple days after I give that person a kidney that will start having rejection happen, like a week. That's our initial sensitization process. So within a week of getting that kidney, we might start seeing rejection. If we've seen the antigen before, it'll still be a couple days. Okay, so stuff like that can control whether or not you're going to react. Most people haven't seen most people are getting one kidney transplant. If you start rejecting it, you might get a second one, but it's almost always going to be a different antigen from the rejection. Okay, so, but this is what guides that stuff. So if my body is attacking the kidney, then that is what we call the host versus the graft being the kidney. Okay. However, in bone marrow transplants, the bone marrow is where the lymphocytes, like your T cells, come from. So then those T cells from the bone marrow that you got can attack your own body. That is the graft versus the host. Are we tracking that? You guys understand the difference? You guys have questions about it enough to know what's going on with that? Because remember, all of your T cells and your B cells, this is why we do bone marrow transplants, that we make sure those match also. Now there's less stricture there because our new bone marrow will have to go through training and things like that before we get B and T cell stuff. So that eliminates some of the risk there, but there's still a little bit of risk there. Okay, so so that we're aware of that. So if the bone marrow is attacking the host that we're transplanting it into, that is graft versus host. So that's the only time we'll see graft versus host is bone marrow transplants. If the host body is attacking the graft, like a kidney, a lung, or a heart, or a liver, then that's host versus the graft. Okay, that's the difference there. There's different types of grafts you can get. Autograft is from your own body. When we do a skin transplant where we like maybe stretch the back skin and then transfer it to like the leg or whatever, or vice versa. That's an autograft. It's from your own body. Isograft is from an identical twin. Almost never going to have rejection from that. Okay. Allografts. These are humans that we are not genetically identical to. Even me and my sister, we are not twins. Okay. We're not identical twins. She's 2 years younger than me. We can't be identical twins. So that would be an allograft. And then a xenograft is tissue from another animal, non-human, like pig heart valves and things like that. All right, so here's a quiz question. Type 4 hypersensitivities like contact dermatitis and graft rejection involve what aspect of the immune response? We're almost done with this chapter, and chapter 18 is easier. I swear it is. Okay, I promise. This one's easier than 16, right? Now that we've done 15 and 16, we have perspective. This one's a lot easier than those, yeah. Well, 18 is super easy. Okay, so this is T cell mediated. Remember, IgE is type 1. IgM and IgG complement mediated, that's type 2. Immune complexes with neutrophil degranulation, that's type 3. And then type 4 is our cell mediated T cell response. We're almost there. Okay, autoimmunity, like anytime we are anti-self, anytime that we are attacking self, then that's autoimmunity. This can involve any of those different hypersensitivities. So it could be type 1, type 2, type 3, or type 4. It just depends. And some of them have multiple going on, okay? This can be systemic or even organ specific. For example, type 1 diabetes, which is down here, right? Type 1 diabetes, we have pancreatic cells, the insulin producing beta cells in the pancreas are being attacked by T cells. That's a very specific type of autoimmunity. But if we have systemic autoimmunity, like we have with lupus and rheumatoid arthritis, we have kind of more systemic inflammation caused by whatever these hypersensitivities could be. So obviously both lupus and rheumatoid involve type 3 with those immune complexes, but rheumatoid and ankylosing spondylitis can also involve type 2 or type 4 hypersensitivities as well. So it could be a combination or whatever. And I'm not going to quiz you like on this necessarily, but I feel like this is going to be relevant whenever you guys start treating patients, having some reference into what aspect of their immune system is involved in that attack. This is usually new to people to know that type 1 diabetes is an autoimmune disease. Most people didn't know that. What specifically is happening is the cytotoxic T cells are attacking the pancreas. That's wild, but that's what's happening in type 1 diabetics. Okay, so it gives reference on how we're going to treat that stuff. So really type 1 type 1 diabetes is really an autoimmune disease. We're really talking about an immune dysfunction, you know, so that's the issue with that. Okay, so how does this cause autoimmunity? Many microbes mimic our own surface molecules. This is protective for them. It might help them evade our immune response, but sometimes if we trigger the immune response still, it can lead to us attacking self. This can be chronic response or it could be acute. So this, like we saw with the acute post-streptococcal glomerulonephritis, I have to think of the word in order to say it, and it has to all come out at once, guys, okay? But if I think of that type 3 that we have after having strep, then that's a temporary thing, it's acute. But sometimes we can trigger a reaction that can be lifelong. And we think that type 1 and multiple sclerosis might be triggered by certain viral infections. There's a lot of work being done on that to figure out what is triggering that and how and why. We think reacting to certain virus triggered us to react to self. So it's molecular mimicry. We also think that the gut microbiome has a lot to deal with how our body is trained on what is self, non-self, and how to react to foreign and non-foreign and things like that. And so much work is being done now to look into that. Like we are actually doing a lot of research now to look into the gut microbiome and how that might lead to Alzheimer's. So there might be indicators in your gut microbiome right now that could say that you might have Alzheimer's. Now, is it only that? No, you would have molecular markers and certain gut biome that would be going on that would make you more or less susceptible to having Alzheimer's, but it is a big area right now. All right, let's talk about our immunodeficiencies, primary and secondary. Primary means it's been there since birth. It's usually genetically related. Secondary means it's acquired later on in your life from something. We already know one that was acquired later in life, and that's AIDS, acquired immunodeficiency syndrome. Right. Okay, so let's talk about these. Oh, here's a question. AIDS, is it an example of primary hyposensitivity? Is it true or false? Go away. We're almost there, guys. Hang in there a little bit. So this one is false. AIDS is a secondary hyposensitivity. So any primary immunodeficiencies or hyposensitivities, okay, primary ones that are related usually to genetic issues. It can be from the actual stem cell. If it's a problem with the stem cell, usually you can't make B or T cells. We usually call that SCID, which is severe combined immunodeficiency. There's a couple of different markers that can lead to severe combined immunodeficiency. But that means you can't make proper B or T cells. If it's related to the T cells, we have a couple like DeGeorge syndrome or ADA deficiency. Remember that your T helper cells govern your B cells too. So if you have a T cell response issue, then you have a bigger problem than just your T cells. You can't activate your B cells either. Whereas if you're just having a B cell issue, we call that agammaglobulinemia or hypogammaglobulinemia. So you're not making antibodies, which we call immunoglobulins. Okay. FYI. Again, agammaglobulinemia, you're not making gamma globulin, which is your immunoglobulins, your antibodies. And so your B cells won't work, but your T cells should be fine. You're going to be at more risk for things that are outside infections, like bacterial infections. Inside response should be okay. T cell deficiencies, you can't activate B or T cell responses. So both are going to be deficient there, whereas SCID, you literally cannot make the B or the T cells. That's a huger problem. And you might even have issues with your agranulocytes and granulocytes, both of them. So any leukocytes you might not be able to make. And so this is boy in the bubble disease, SCID. Okay. Severe combined immunodeficiency. There's different levels of it depending on which aspect is affected. The boy in the bubble disease is the boy in the bubble disease because this is an X-linked version of SCID. In X-linked SCID, which is the most severe one, all right, if it's X-linked, women get 2 X chromosomes. Men only get 1 X chromosome. So women can have a backup gene, but men only get 1 version of it. And so that's why we almost never see it in women, because women would have to get a gene from a man that was a problem and a gene from a woman that was a problem. The man that would have the problem would have had SCID. And those men almost never live to childbearing age. Almost never. That's why it's boy in the bubble. It's not man in the bubble. Because they die. This is sad, but it's the truth. So when it's the X-linked SCID, that's the issue. There are other versions of SCID. And now more and more, we're seeing genetic gene therapies for things like this that can help accommodate that issue. Okay. All right, so moving on to the secondary. Again, you can get secondary immunodeficiency from infection, like with HIV. You could also have infection of other immune cells that could lead to depletion of your immune cells from the infection. It could be non-infectious metabolic diseases. It could be chemotherapy, or it could be radiation exposure. Radiation either from treating cancer or radiation from exposure to radiation, just like in the wild, okay? Or from X-rays and things like that, all right? So AIDS is the most obvious one. Our T helper cells can be infected. Most importantly is our T helper cells. The depletion of our T helpers leads to immune dysfunction. We can't activate our captains, and our captains can't activate anything else. So AIDS occurs when our T helper cells are reduced below a certain threshold. Is this true or false? It's not meant to be a trick question, I promise. Is that when AIDS occurs? When our T helper cells are reduced below a certain threshold. Okay, so this one is true. So that's how we basically, that's our main indicator of AIDS. The T helper cell count gets below 200. Yes, 200 is the number. And then we also see opportunistic infections coming along with that, but that's usually because our T cell count is low. Okay. So that's what defines it as a syndrome. Cancers like leukemias or certain B cell tumors or T cell tumors can also lead to the development of decreased immunity as well. All of our energy is being put into making this tumor B cell, and it's not making effective antibody, it's just a waste antibody. And then we're not able to direct the rest of our immune system because of that. That can lead to that as well, let alone the treatment for the cancers. So that is it for chapter 17. Any questions before we move on to 18? 18, almost all of it, not all of it, but a good portion of it is just review stuff. It's just categorizing the stuff. So it should go by pretty quickly. So we're going to switch over to 18. We'll have to re-sign in, so just FYI. Lecture, okay. Make sure we're signing in. Here it is, 9550565. It should be a lot shorter. And I even have like a little bit of a mini key that goes with it. And we'll talk about it. Starting to cool down a little bit. It's not quite as hot, but it's still pretty hot in here. All righty, so we're gonna go ahead and get going. And if you're still signing in, we're gonna go ahead and kick it. Again, our learning objectives for the chapter. We're gonna keep going. Okay, so this is the main idea of this whole chapter is categorizing our tests, okay? There are 3 major categories and then an other. Our 3 major categories are phenotypic, immunologic, and genotypic. And then, yes, there's an other. The other tests, I'm just going to list them real quick, are going to be our imaging tests. Hey, Heather. Hey, friend. You too. All right, so our imaging tests are going to be in the other category. And then we're going to have the MALDI-TOF. I can't spell it, apparently. We'll talk about what MALDI-TOF is in a little bit, so don't freak out yet, okay? TOF. Okay. Phenotypic tests. These are all of our biochemical, our differential and selective media. This is going to be phage typing. If you don't remember what some of these are, don't worry, we're going to talk about them. This is going to be maybe Kirby Bauer, just depends on the context. There might be some other ones that I'll be reminded of. Fish, did you say? That'll be in the immunologic, but that is one, right? Actually, it's genotypic. Yes, because that's nucleic acid. Okay, so immunologic ones, remember immunologic is going to be antibody antigen. These are going to be obviously ELISA. We know that one. This is going to be immunofluorescence. Okay, that is also known as IFA. Okay, this is going to be Western blot. Our genotypic tests, this is going to be PCR. This is going to be nucleic acid hybridization. Which is known as, a version of this is known as FISH, which is basically using fluorescence in that nucleic acid hybridization. And then also microarrays, which is kind of also a version of nucleic acid hybridization. I should put it that way. No. So the PGLO test, just to talk about that. PGLO test, we took bacteria, put a plasmid in it that made them glow. But did that tell us about whether the DNA matched up with a patient sample or like any diagnostic thing? No. It was a tool that to put a gene into bacteria. And imagine that instead of putting GFP into bacteria, we put insulin, or we put genes that code for, monoclonal antibodies that block inflammation like Humira, or whatever else, growth factor, whatever other sorts of things we can make bacteria make. So that's a tool in genetic engineering, using the bacteria to make them crank out something. Here, we're doing this as a diagnostic test. So these are all diagnostics. Phenotypic, immunologic, genotypic, and then other, okay? So you must fall into one of these categories. And these are the only ones that we're calling as other, okay? And almost always, most of the exam questions are going to be basing off of whether it's immunologic or phenotypic or something like that. We must know what the tests are too, but we've talked about most of these. We've talked about nucleic acid hybridization. We've talked about PCR. So this is just now showing us how they're used in diagnostics. Are we ready? I'm gonna crank through them, all right? I'm gonna leave that stuff up on the side while we go through this. Phenotypic tests. We're observing the microbe's characteristics, but we're not using antibody or antigen. That would make it immunologic. And we're not using genetics. That would be genotypic. So PCR is genotypic. That's using their genetics, looking at their genetic sequence. Now, whether or not they have red colonies on the plate, whether or not they turned the media yellow from fermenting glucose, whether or not they turned pink on McConkey agar, those are phenotypic tests. Are we tracking that? We're looking at their actual we're looking at their actual genetic sequence, then that's genotypic. Right? Now, did their genes determine whether or not they could ferment glucose? Yes, but the results are depending on their phenotype, the physical expression of that. Okay, are we seeing the difference there? Okay, if it depends at all on antibody or antigen, it's immunologic. All right, let's get into it. Sampling of our stuff. Skin cells, biopsies, urine, feces, blood, swabs of tissue or secretions, anything like that, we can send it to the laboratory, usually in a transport medium that keeps the bacteria or the virus or whatever in a safe, happy, alive state until we can get it to the lab. You've probably seen these before. They have like a little swab inside, and you just have to worry about the swab thing. But when it gets to the lab, they're going to put it on different media. They're going to put it in PCR or whatever it is that they do in the lab. And then you would order this. It used to be done on paper. Now it's done in like Epic and things like that. That whatever test you're ordering, whatever you mark up, and whatever like labeling of a specimen. This stuff is extremely important. I cannot stress enough. When you get into healthcare, especially if you're going into human medicine, in veterinary medicine, usually the vet has their own kinds of systems on how they deal with this stuff. But in human medicine, if you're using, you're almost using the same kinds of tubes and labeling systems and everything like else that everybody else is, usually Epic or something like that. And so Care 360 or Epic or anything like that. And so this type of system, you must label the tubes a certain way. There's certain information that's printed on the tubes on what kind of test is going to be done and everything like that. And they all have meaning, and you'll have to learn it for your hospital on what those abbreviations stand for. But it is important to have reference for that whenever you guys get into that in healthcare stuff. So once we get the specimen, we usually have to cultivate it if we're going to do any sort of phenotypic testing. Sometimes we can do gram stains. I should have put that in the phenotypic testing too, staining. Like gram stains or endospore stains or acid-fast stains. All that would fall into the phenotypic stuff, okay? So sometimes you need to cultivate it first, and you might, if you have reference for what's going on with your patient, if the patient has diarrhea, you might want to culture it on McConkey or EMB. If your patient has a skin infection, you might want to culture it on a mannitol salt agar, for example, to get some reference in it too, and to select against anything that could be contaminating in that situation. So selective and differential media might be used. Remember, selective, certain things will grow, some won't. Differential media tells you the difference between what is growing, usually by color change. And we can use whether they're positive or negative for a test using a dichotomous key, which we're going to use in the lab at the end of the semester. It's coming. And so probably either the end of this week or next week sometime, I'll give you guys the dichotomous key to start looking at. Most of you guys, some of you guys will be able to look at your organism now. We already know what gram positive is for table 3 and for table 5. But I will give you the keys and we can start looking at that stuff. Most of us will rely on the last test of the whole semester to get our results done. Okay, so FYI on that. But it works the same way as this. You have cockeye that you saw on your organism. Was it gram positive or gram negative? Gram-positive cocci, was it catalase positive or catalase negative? Remember, catalase is the enzyme that breaks down hydrogen peroxide. So if you're catalase positive, you'll have bubbles, turning that hydrogen peroxide into oxygen and water. The oxygen is the bubbles. If catalase negative, streptococci are catalase negative, for example. But for catalase positive cocci, then you might be a strict aerobe or a facultative anaerobe. What does a facultative anaerobe do? Ferment. So if your organism turned any of your tubes yellow, you would be a facultative anaerobe, for example. So you already know some of this information about your organisms, for example. Okay, so this gives reference to those tests that we're doing, using it as, are you positive or negative for a test? So you will only have two answers on these. Okay, either are the thing or you aren't the thing. All right, how many choices are offered at each stage of a dichotomous key? Basically, at each question set. I mean, yeah, this is not meant to be. This is not meant to be difficult. Okay. At each step, you're only faced with how many choices? All right, it's two. Dichotomous, right? All right, so biochemical testing is a type of phenotypic testing. So looking at whether your organism ferments or doesn't ferment, whether it can utilize citrate or can't utilize citrate, what it does with the litmus milk, or whether or not we produced urease. Those are all biochemical tests, and they are all type of phenotypic test. Okay. All right. So to put that in perspective, here's the idea of that card that I was telling you about. Each of these wells would represent a different chemical test. So well one might be glucose fermentation, sucrose fermentation, lactose fermentation, glycerol fermentation, urea, MR, VP. Each well would be a thing, and we'd be able to run it all at once, fill it with a little bit of culture in each well, and then get all the results all at once after one incubation. We did this very commonly in food testing to try to identify to verify organisms in food samples. If somebody got a positive PCR, they often wanted us to do the biochemical testing afterwards to verify that the PCR wasn't just contaminated with something. Because again, if it's contaminated, we're working in a lab that's filled with E. coli and stuff like that. We have to run positive samples next to negative samples. If E. coli got somewhere in our lab and it accidentally got even one bacteria into a PCR, it could pop positive. But if that food sample didn't actually have that in there, then it wouldn't show up with biochemical testing. So we always use this to verify if it popped positive with that stuff. All right, so there's that as a reference. But anyway, so we do this. These are very expensive. These cards are probably upwards of $1,000 a pop. So we don't want to use these unless we really need to use them. Okay. All right. Tests that are based on an organism's metabolic differences as determined by color change are known as we often think of the color change thing being the differential thing, but what categories are differential media falling into? This will be our biochemical tests. Biochemical tests are often what basically trigger that differential aspect, okay? All right, antibiotic susceptibility. Sometimes if an organism can grow in the presence of an antibiotic or not, can help us determine its identity as well. In that case, we're not just using Kirby-Bauer to determine how to treat it, but also to help identify it. So in some cases, we can use Kirby-Bauer to identify an organism. So that would be the case of that situation. Not commonly used, but certain species. You can also use phage typing. We learned way, way, way back in chapter 7 that a bacteriophage is a virus that infects bacteria. But that bacteriophage only infects one species of bacteria. So if I have a bacteriophage, let's say T4, okay, T4 only infects E. coli, and my patient has diarrhea. So I might culture up the E. coli, mix it with, or I might culture up my patient's diarrhea. Sounds gross, but this is facts, okay? Culture my patient's diarrhea, mix it with some T4. If we see plaques forming, death of the bacteria are killed, that means that the phage infected it. That means it has to be E. coli. If the patient has bacteria and bacteria grew, but there's no killing of the bacteria, then it's not E. coli, for example. Okay, so we can just say whether it is or isn't. This is commonly used for identifying salmonella. So phages that infect salmonella. If the patient's bacteria are killed by the phage, that patient has salmonella. Okay, so it's like using a second level of infection. Infect the bacteria. If they're susceptible to the phage, then they have salmonella, for example. So that's phage type bang. So that's under the phenotypic. Also having reference. If your patient has E. coli in their stool, is that abnormal? No. But if their stool is overpopulated with E. coli, is that abnormal? Yes. So having that reference. Whereas if your patient has any bacteria that are acid fast in their sputum sample, they have an infection, tuberculosis, for example. Okay? So that reference as well, how much and where and what the organism is, that gives us reference as well. Phenotypic methods often rely on culturing, which is a 18 to 24-hour process or longer, depending on the organism. So that could be a problem. So that's a downside of our phenotypic. So here's a little mini list of our phenotypic methods. All right, here's a quiz about them. Select all but apply. Which of the following would be an example of phenotypic tests? All right, so this will be the color change in the differential media and the phage typing. PCR amplification and fluorescent hybridization will be genotypic. Western blot and ELISA will be immunologic. All right, so now let's get into our immunologic. Much of our immunologic tests are serology tests or serological tests. Okay, they were going to rely on antibody or antigen in the serum. So that's serological. Okay. Serology, where we're having unknown antibodies being tested with known antigen, or unknown antigen being tested with known antibodies. So this should sound familiar. We learned about this with ELISA. If you're testing for antigen, you need a known antibody. If you're testing for an antibody, you need a known antigen. This tracks for all immunologic tests, not just ELISA. So if I'm talking about ELISA, immunofluorescence, or Western blot, then those are all immunologic tests that rely on that direct or indirect. Direct and indirect apply to both of those. Okay. All right, here's the idea here. If you have a patient's serum, we will add a known, like when we're seeing if they have an antibody, we'll add a known antigen to see if it reacts. If we want to know what the microbe is, we might add antibodies to see if it reacts. So it just depends. Known and unknown. What's the known and what's the unknown? What's the question you're asking? Does the patient have the antibody? And that is indirect. Does the patient have the antigen? That's direct. Okay. So here's a list of our immunologic methods. Agglutination and precipitation has to deal with whether you're dealing with whole cells or parts. Agglutination is cells. Precipitation is antibody antigen, so parts of cells. Immunochromatography. This is like your home COVID tests. Okay, so it runs across a paper and causes the color change. Western blot, we're going to be running things out on a gel like we did with DNA, but it's protein this time. Transferring it to a paper and then seeing if antibody binds or antigen, depending on what you're looking for. Okay, but it runs off the same idea as the DNA gel electrophoresis, but with proteins this time. Fluorescent antibodies, taking a patient specimen, like a swab of nasal stuff or whatever, putting it on a slide, and then seeing if the antibody binds by looking at the antibody being bound to a fluorescent molecule of some kind, causing a sample to glow if it's there or not glow if it's not there. ELISA, we already learned about that. Color change in the well, that's dictated by a secondary antibody linked to an enzyme. Then in vivo tests, like the TB skin test, that doesn't rely on antibody antigen, it relies on T cell antigen. Okay? But it's still immunologically based. Okay, so here's a question. What are indirect immunological tests looking for? Indirect. Indirect. Does the patient have? We're almost there. Should be an easy day in lab today too. Labs should go by pretty quickly from now on. All right, a presence of antibody. Does the patient have the antibody for the indirect? All right, looking at it, we will look at agglutination, whole cells being bound up and settling, precipitation, soluble molecules, immunochromatography always looks like this, whether you have a color change of line or not, basically, okay? And it still depends on antibody or antigen. Antibody titer, we can measure the amount of antibodies in a sample, often using ELISA or something like that, how much antibody is present in there. Serotyping, this is basically saying that this antibody binds to this type of E. coli. This antibody binds to this type of E. coli. This antibody binds to this other type of E. coli. Then we would name each type with their own different antibodies as serotypes. Naming organisms based on different antibodies binding to them. That creates a serotype. Western blot, this is the idea. We're going to spread out proteins based on their separating by electricity, based by their size, just like DNA. The bigger ones get caught up at the top, the smaller ones travel faster. Once we separate out, now we can see more specifically. We're not just seeing, is my antibody binding to an antigen? We're saying that my antibody bound to something that was this size of a protein. This size of a protein, now that does match up with the spike protein of the COVID and stuff like that. So we're not just looking to see if there's interaction, but interaction with specific sizes of proteins that can be way more specific and a lot more sensitive as well. So again, very, very specific, very, very sensitive. You thought ELISA was specific and sensitive. This takes it to the next level. Also very expensive to run these, but in some cases, this can be useful in identifying. So again, we take our patient sample, we run it on the gel, we transfer it to the paper, and then use antibody to see if that lines up where it's supposed to on the gel. Okay. There's a little video on it. Apparently, I didn't link it to my thing, so that's nice. I won't subject you to it now. All right, which immunological test involves gel electrophoresis with proteins and a specific filter paper test? Hopefully you just, not this, it is what we just saw. One relies on gels and a special filter paper and then looking for antibody antigen interaction. All right, Western blot, Western blot. All right, remember that in any of these immunological tests, it can be looking for the antigen or looking for the antibody. Here's an example of looking for antigen. Fluorescently labeled antibodies binding with antigen in your patient's like nasal swab or skin swab or whatever. If it binds, it'll glow under the light. If it doesn't bind, there will be no glowing. So this is like looking at it that way. So this is immunofluorescence. Immunofluorescence, also known as IFA. We're looking for, does the patient have the antibody versus does the patient have the antigen? Again, it's still indirect and direct. We've already learned about ELISA, so I'm not going to talk about it again. But we are relying on antibody-antigen interaction. Does the patient have the antibody or does the patient have the antigen? And the color change in the well determines the difference, right? So we have indirect and direct. And we have little images here if you need to review them. The direct, remember the sandwich goes directly in your mouth. All right, and then that color change result determines the difference there. All right, so what are direct immunological tests looking for? We're directly looking for the antigen, which is part of the pathogen, right? But it is the antigen. Okay, so there's one more type of immunological test, which is the complement assay. And it's basically relying on if your sample, like basically the bursting of red blood cells is your positive or your negative. Positive, the patient has the antibody, it binds with antigen and therefore can't lyse the blood cells. If you're negative, when we add antigen, complement will lead to lysis of the red blood cells. So if your patient has the antibody, they won't lyse it. If they don't have the antibody, they will lyse it. And this is a complicated one. I don't ask a lot of questions about it on the test because it gets confusing with people. All right, so FYI, but it is a thing that we can do for diagnostics. There's a video on it on the lecture online if you're interested in watching it. Okay. In vivo testing, this doesn't use serum outside of the body. Instead, we're testing it in your body for an immunological reaction. This will be things like even looking at allergen reactions. So whenever they give those little spots on your back and then see if it welts up, that would be an in vivo test. But the one that we talked about previously was our PPD tuberculosis skin test. That's in vivo. And it relies on reacting to antibody. In vivo means in easy question. I'm skipping. Yay, the body. Okay, good. We're back with specificity and sensitivity. We've heard it before and it was confusing before. And so this is where this is your opportunity to get it basically cleared up in our minds, okay? Specificity, okay? If we're specific, if we're very specific, we won't have false positives. What does that mean? A false positive means we're giving a positive when it's not actually positive. It's a false positive. So if you're specific, you will say this person is positive for this specific thing, not positive for the thing that looks like it. So one of the examples that we had was basically, okay, so here's an example that came from somebody that I know in real life. They had a test done on their baby that they were carrying. And that test came back as a screening test as positive for trisomy 21. Okay, but it was not a very specific test. It was a very sensitive test, but not specific. So if the test came back as trisomy 21 for the screening test, they wanted to do a more specific test like amniocentesis and other tests that are done for looking for nucleic acid hybridization like FISH, okay? And so that test can come back negative, and it did for this person, okay? And so if it came back as positive for trisomy 21, what did that mean? Maybe the uterus had trisomy 21, but not the baby. Or maybe the mother had tissue in her body that had trisomy 21, but not the baby, and it just contaminated her sample when they did the testing, stuff like that. Are we tracking the difference between that specificity there? Okay, so there's that as an example of specificity. Going to, you're on your flu medicine and you pop positive for methamphetamines. Did you take methamphetamines? I mean, I'm hoping not, okay? But you might still pop positive for it, right? And that's not specific enough, that's why. It looks like methamphetamine. That's a false positive, right? So that's the specificity. Sensitivity is saying that you need more or less of something to be positive for. So when our patients, 100 of them had the flu and only 98 of them tested positive, that meant 2 of the patients had the flu but tested negative. That's a false negative. That's a false negative. That's dealing with sensitivity. Are we tracking that a little bit better? I hope that by now we've covered it a little bit, but you need to know the difference because you know it's going to come back up on the unit 3, and you also know it's going to be on your final as well. Just FYI. So getting the difference. Now, do we want tests to be more specific or more sensitive? Both. Because it's not a choice between. We want both. Okay. So that's where a lot of people get confused too. They think it means one or the other. No, we want both. Okay, so we did it. If you have more questions about it, let me know. Which aspect of testing is determined by how many people test falsely positive? I know following the P's and the N's is helpful, and it was helpful here, but we also have to have regard to how it's applied, which is what caught us a lot on the exam. Y'all know it's not going to be the same question, right? Okay. All right, moving on to the genotypic methods, anything looking at the actual genetic sequence, the ATCGs of the genes, okay? So nucleic acid amplification tests, you'll often see them called NAATs. Especially when you guys are doing your research and your research presentations and stuff, you'll be like, oh, they use NAATs. I might even ask you, well, what type of NAAT? Because if it's PCR, that's a type of NAAT. Okay, so just FYI, PCR falls into the NAATs because what does NAAT mean? Nucleic acid amplification test. If we're amplifying or copying the DNA, that falls into NAAT. And PCR is a type of NAAT. Okay. Hybridization. We are taking a genetic code, AACTGGG, and linking it to something fluorescent or something like that, and then seeing, does it match with my patient's cells? So if we're doing that kind of one-on-one, that's FISH. If we're doing a big plate with a whole bunch of genetic sequences and then seeing if your patient sample matches anywhere on that plate, that's microarray. You can also use whole genome sequencing. So again, PCR making copies of the DNA. If it makes the copy, then you are positive. If it doesn't make a copy, you are not positive. Okay? Hybridization, using genetic probes to see if they match up with the sequence in the patient sample or on the plate. You should label them fluorescently, literally make them glow a certain color. And if the glowing sticks, then it means that the sequence is there. So let me show you an example. Fish is commonly used for genetic testing type of stuff. But let's say we're looking for a sequence that is A, C, T, T, G, A, and whatever. This signals that this person has cancer. And this is in their biopsy. And then out here we have a probe that has T, G, A, D, T, T. See how they match up with each other? And this guy is linked to something fluorescent. It glows a color. If that sticks to your patient sample, your patient has the genetic sequence, and therefore they have the genetic sequence. We can look for cancer sequences this way, but we can also look for bacteria sequences. So if the probe matches, then that patient has the bacteria gene sequence. But this relies on the gene sequence, not antigen or antibody. Okay, so if it relies on antigen antibody, that's immunologic. If it relies on gene sequence, genotypic. So these are using probes, kind of like our antibodies, but instead of relying on antibody antigen, genetic sequence here. Okay, I'm gonna leave that up for a second. This is an example of that. You did a gram stain and it showed staphylococci, but are you sure it's Staphylococcus aureus? So we can use a probe that looks specifically for Staphylococcus aureus DNA. If it sticks, it glows. And then we can diagnose it that way. This is an example of that. Fish, fluorescent in situ hybridization. This is a genotypic test based on genetic sequence. You can also sequence whole genomes. This is something what we might do if we have a new drug-resistant strain, or if we have a complete unknown that we're trying to categorize or something like that. So we usually do this in a shotgun method to sequence that. We can also use microarrays, which is usually using nucleic acid hybridization for a lot of different gene sequences all at once. We can have a whole plate with a whole bunch of sequences on it, put the patient sample on there, and whatever it binds tells us about positive or negative for certain gene sequences. All right, here's a question. Multi-select, all that apply. Which of the following would be an example of a genotypic test? Erase everything just yet. All right, good. So this is going to be PCR amplification and fluorescent hybridization, also known as FISH. We can do a bunch of these tests all at once on like a chip and like just add the patient sample. We can do phenotypic, immunologic, and genotypic all at once on chips, and then just like put the patient sample, plug it into a machine, let it run for an hour, and then it'll tell you if it's positive or negative for all these different types of tests at once. They're expensive, but it's useful in like field settings, especially like in areas that don't have laboratories available to them, like in third world countries. You can buy these machines for them and they can do these types of testing for a select number of testing things. So it's a lab on a chip ideology. The last thing is our other category. Our imaging falls into this, whether that's X-ray, CAT scan, all of that. That can tell us information about stuff as well, but it's not based on phenotype, immunologic, or genotypic, right? It's an other category. But also MALDI-TOF. MALDI-TOF is a type of mass spectrometry. It relies on the mass and the charge and the time of flight. We're going to shoot a laser at the specimen. It could be bacteria, or it could be drugs, could be any molecule ever. Shoot a laser at it, and parts of the ions fly off. And then the time of flight, how much time the ions spend in the air, is measured. Okay, so that's what it stands for. And this is basically based on the actual molecular makeup of these things, and it creates a profile, and every molecule has a different profile, different time of flight of the parts that are flying off, and each molecule has its own footprint that can determine for us what is this molecule in this sample based on the time of flight of its parts. You don't need to be able to analyze it, okay? You can't. But have an idea of this is what we're talking about. So those peaks pop up as the time of flight of the parts of molecules, and that tells us about what the molecule is. I had a video and I uploaded it on purpose so that it would play, but it's not going to show it, so it's awesome. I did this on purpose. Whatever. It would have been nice if it played. All right. Okay. So anyways, imaging falls into the other category as well. What is MALDI-TOF used for? What is it actually doing? Is it sequencing the DNA? Is it culturing the cell? Is it synthesizing the protein, or is it allowing us to identify pathogens based on its parts? Yes, pathogen identification based on the parts, the molecular makeup. And that is it for chapter 18. We have made it. And so we're going to head up to the lab next. So I'll see you guys up in the lab at 11 o'clock. And we'll get going with that. Thank you guys. We did great. We made it through unit 3. Email me with your questions.
I literally don't know where mine went.
Yeah. You're fine. Yeah.
Thank you.
Yeah.